Okay, I just started the recording, so I'm going to start presenting this second discussion forum that I'm very happy to have Anna and Alejandra here to share this important topic. So before we start presenting you and also starting presenting this topic, I only wanted to introduce something about, so a little bit more about our study group that is called Qhali Peru. Qhali Peru is a study group in dental public health that just started a few months ago, and we have the mission to promote the specialty of dental public health among undergraduates and graduate dentistry students from Peru, as well to contribute to the development of their skills as researchers in this area, to generate spaces for scientific dissemination, and in a long term, to propose interventions to improve the oral health and reduce inequities in vulnerable populations from this country and also in other countries from our region. So our vision is to be a solid study group with members from all the Peruvian regions and dental public health researchers from different parts of the world who can collaborate with each other for their development as researchers and to generate or improve oral health interventions in different vulnerable populations around this country. So we have some guide principles that also help us to accomplish this mission and vision and goals and other goals such as the teamwork, the commitment, leadership, responsibility, solidarity, honesty, and punctuality. So this is the directive board for this first year. So here also in this meeting is Maria Pia Leca, who is our vice president, Alessandra del Águila, who is a web manager, and Jessica Velázquez, who is our director of communications. We also have two important teams in our study group, the communication team and the web team. Here, for example, in the communication team are all the coordinators for each discussion forum that we will have in the following year. And I am very happy to have been working with all of you girls. The teamwork that we are having is very excited because we are having some results and we also have more than 70 other members who are undergraduates, graduates, and alumni from the different faculty of dentistry around Peru. And so one of the first activities that we developed for this first year are the discussion forums, that has the aim to increase the knowledge of basic dental public health concepts and the awareness of the existence of this specialty. Sorry. Oh, I have a lot of... Yeah, okay. So it's to increase the knowledge of basic dental public health concepts and the awareness of the existence of this discipline among all of the members of our study group and also among the general public. That's why we are trying to use different social medias to share all the information that we are learning in this discussion forum, for example. So we organized 6 discussion forums for this year. Each forum is led by all of this committee, who are all of our partners from the program of dental public health here at U of D. We already have the first discussion forum that in May. It was very, very helpful to understand more and to learn more about also the other 3 collaborators who did a specialty of dental public health in King's College London in UK. So we in this forum we shared a lot of experiences about this area, and as a result we had also this first publication to share like the most interesting thing of this first discussion forum. So the group number 1 created this publication as a summary, and today we have the opportunity to listen about this other topic that is called the impact of the social determinants of health on oral health inequities. Our chair is Ness, and the collaborator for this discussion forum is Alejandra García Quintana. And now I'm going to introduce the coordinator of this second discussion forum, who is Karla León Malpartida. Karla is part of our communication team. She is a last year student of dentistry at the Universidad San Martín de Porres in Peru. She also participated in the Global Oral Health Education Module in 2021 at the University of Glasgow in the dental school. She is a student representative at the COP26, including oral health within the 17 ODs. And as I told you, she's part of one of the leaders of our communication team, and I'm very happy to have you in our study group, Karla. So I'm going to let you introduce Ana and Alejandra to start this discussion forum.
Good evening, everyone. My name is Karla. So I'm so glad to introduce our members of this discussion forum. Ness is a registered dental hygienist with over 10 years of clinical experience, a first-year master's student specializing in dental public health in the Faculty of Dentistry at University of Toronto. Anna's rich familiarity with Canada's healthcare system by way of her experience as a frontline oral health worker deeply connects to her research interests in the field of dental public health. The next one, please. Anna's research interests lie in qualitative methodology to examine oral health markers as indexed by the social, cultural, and political context of one's environment. She's also interested in the critical examination of oral healthcare systems as byproducts of state policy and governance. Her thesis seeks to analyze the relationship between parental ethnic identity and oral health and nutrition outcomes in Indigenous children living in Northern Ontario. So we're glad to have Ana in our discussion forum. And now I'm gonna introduce Alejandra García Quintana. She's a graduated dentist from the Universidad Central de Venezuela. She's a Master of Science degree in Public Health with a mention in Behavioral Science, Education, and Health Promotion from the University of Texas. She's a Health Leadership Fellow at the University of Texas, and her area of interest is maternal and child health during the first 1,000 days of life, design and implementation of health, promotion programs in environments of health, prevention of chronic and non-communicable diseases, M health as a tool for promotion of the health, and microbiome, epigenome, behavior interaction with the process health illness. So we're glad to have you, Ana and Alejandra, in this discussion forum number 2.
Okay, so now Ana and Alejandra, this is all of you, so you can share your screen to start this discussion forum.
Hi, everyone. Hola, amigos. I'm so excited to be here with you all today. Thank you so much for taking time out of your Saturday night to be with us and to learn with us. And yeah, I'm really, really excited about this topic, and I hope that there's something for everyone here. And if not, please give me your feedback. This is a learning opportunity for me as well. So please, any feedback that you have for me would be so welcome. I'm going to share my screen. I have to make sure to share my sound so that one of my videos can also, so just please bear with me for a sec. No, you guys can see everything, right? Okay. Okay. All right. You guys can just see my slides?
Yes, we can see
Okay.
on the slide.
Okay, thanks for bearing with me. Hopefully you guys can hear the sound in my in the video on the next slide. Okay, so the topic of today is the impact of the social determinants of health on oral health inequities. So first off, I wanted to go over kind of the most basic but crucial concepts that we talk about constantly in public health, the first of which are the social determinants of health. And likely most of you have some familiarity, if not a lot of familiarity with this topic, but it is such a building block concept that I think it's worthwhile for us to kind of go back and to refresh our minds on kind of what it is and what it encapsulates, because it is really complex. So I'm going to play a brief video that kind of provides us a definition and some examples that Karla had suggested. So let's hope it works. Can you guys hear that?
Yes.
Yes.
Awesome. Okay, thanks.
I should really go to the doctor, but the closest office is an hour away. I can't take that much time off work.
Since I got laid off last month, I felt so stressed. I need to provide for my kids, but no one is hiring. I don't know what to do.
I used to know every single person that lived on my block. Now I don't even recognize the place. There's just no sense of community anymore.
When we talk about how to maintain our mental and physical health, we often focus on things like eating healthy and going to the doctor. But our health isn't just affected by the choices we make, it's impacted by our environment. The conditions in which people are born, grow, work, play, learn, and worship are called social determinants of health. Social determinants of health can be visualized as a river with two categories of determinants: upstream factors and downstream factors. Upstream factors occur at the systemic level. Examples include institutional discrimination and accessibility of education, employment, housing, healthy foods, and quality health care. Downstream factors are specific to individuals. Examples include employment status, level of education, and aspects of identity such as gender, race, and disability status. Just as building a dam upstream impacts the flow of a river downstream, upstream social determinants directly affect downstream ones. Consider race. In and of itself, race does not impact health. Rather, systemic racism leads to consequences like less access to employment and education, which in turn negatively impact health. To begin to recognize the relationship between social factors and health, consider these statistics. Suicide rates are highest in the Western American states and in Appalachian regions. Non-Hispanic Black individuals have the shortest life expectancy of any racial group, and the mortality rate of Black infants is more than double that of white infants. And as compared to people with an annual family income of $100,000 or higher, people with a family income of $35,000 or lower are 5.4 times more likely to experience serious psychological distress, but 10.6 times more likely to go without needed care due to cost. Tackling the social determinants of health, especially the upstream factors, can seem like a huge task, but we can all make a difference by advocating for change in our own communities. A good place to start is with the U.S. Healthy People website. This site has stated goals related to social determinants, which are aimed at improving the following. 1. Access to jobs, food, and housing. 2. Access to education. 3. Community connectedness and inclusion. 4. Access to health care and health literacy. And 5. Neighborhood safety and housing quality. Throughout this process, remember that systemic issues impact individuals differently, that people are the experts of their own lives, and that social structures won't change overnight. But with empathy and sustained effort, we can better the health of everyone.
All right, before I continue, thank you, Karla, for that suggestion. And I just want to add to Camilla or Alejandra, if either of you guys want to kind of pop in, just please unmute yourselves and feel free to interrupt me. Okay, so kind of the biggest takeaway from kind of the video and the social determinants of health is that health is not just a choice, but it's shaped by structural and individual conditions. It's what we do, it's our behaviors, but it is also who we are, our age, our ethnicity, our gender, and where we live and work. But it also includes our social networks and supports, among other things. But one key message that I think is important to take away is that one determinant that has probably the largest impact on our health is our socioeconomic status. And what it encompasses is income, education, and employment. So socioeconomic status is a byproduct of these three things. And it determines kind of the amount of social class or power that an individual has. And this social power directly influences how many health-gaining resources are available to you and how you can cope with ill health events. As health professionals, we all know that access to healthcare services are also a determinant of health. And we also know that not everyone has the same degree of access to dental health services depending on our income, whether we live in an urban or a rural area, among others. And so when different groups of people do not have the same access to healthcare, this may also lead to health inequities. There's often confusion about the difference between inequality and inequity, and often these terms get used interchangeably, which makes it harder to know when it is appropriate to use each term. So when I was first learning this concept, I found this picture really helpful. It's a visual that has stuck with me, and I remember every time that I have to read or discuss the topic that uses these terms. So I'm hoping that this will be helpful for you guys in the future as well. And it's taken directly from the Weintraub reading that was posted for today's session. So likely you guys have seen this at least. So equality means that everyone has the same thing. In the picture on the left, we can see that everyone has access to the same size box to stand on to be able to see some sort of sporting event in the back. But that doesn't give everyone the same opportunity to see the event and participate. Whereas equity means having the same opportunities. So in the picture on the right, we can see that different people have different size boxes depending on their need. Now, everyone can participate to the same degree, but do so by receiving different things. This is also known as leveling the playing field. And by definition, inequities are unfair, unjust, and avoidable. But not all inequalities are inequitable. So for example, having periodontal disease in later stages of life might not be equal. It might not be unfair, or it might not be fair, but it is definitely not necessarily, but it might not necessarily be unjust or avoidable. And this is kind of where it gets a little bit tricky. So if I've confused you more with this example, please let me know during our discussion time. And before I move on, do Camilla or Alejandra, is there anything you guys want to add right now?
Thank you so much for the invitation. Yeah, I wanted to say hello before I interrupted you. I think this discussion is very important, and the way you showed it, like with this graphic, is very representative to understand like the difference of terms. I am always drawn to understand a terminology, and then that will help you see the context better. So I think it's a great start for those, if in the group anyone is interested in knowing more about this, is understanding these terms, because at first you might think they all sound the same, but those little differences, especially in social sciences, And when we talk about health determinants and social determinants, it's a social science applied to a bioscience, if you can call it that way. So I really found this picture representative and easy to follow with.
Awesome. Yeah, I agree. It's so easy to use them interchangeably. Even when I was making this presentation on one of my slides, I wrote inequalities when I meant to write inequities, and I had to go back and change it. So, you know, it's the little details, but they do make a difference. Okay, should I move on?
Yeah, I only wanted to ask you if you, Alejandra or Anna, have another example for inequality or inequity. Something that helped me also to understand is that inequity has also is also related with unfair situations, right? So can you provide us another example of inequity in the oral health context, like with oral health related?
It's on the next slide.
Oh, great.
Okay.
So let's move on.
Let's move on, and then Alejandra, you can, yeah, whatever I don't include, you know, whatever you guys want to add on, then we'll take it from there. Before the oral health inequalities, I just wanted to briefly talk about the commercial determinants of health, because one of the readings by Jameson et al., it was taken off our reading list about 2 weeks ago, but I know some folks have read it because they posted some questions in the discussion board on the topic. So no worries if you didn't read it, if you didn't read the reading, because I'll go over some of the most important points, but I didn't want to just kind of disregard it for folks that did get a chance to read it, because it's also a really interesting, important topic. So corporate activities such as the marketing of harmful goods, including unhealthy foods, tobacco, sugar-sweetened beverages, and alcohol, affects our health. Corporate activities shape our environments, our social norms, and determine the availability, promotion, and pricing of consumable goods. Corporations will produce and promote foods commercially for profit, and large, especially transnational cooperations, are known to target low-income ethnic minorities and specifically young children through aggressive marketing. And they often produce and sustain unsafe working conditions. And they also influence what the normal behaviors are in our society, such as appropriate use of alcohol or cigarette smoking in specific social contexts and situations. And for dentistry, the three biggest contributors to poor oral health that are kind of known as commercial determinants are alcohol, sugar, and tobacco products such as cigarettes. The three oral health diseases connected to these consumables are, of course, dental caries, periodontal disease, and oropharyngeal cancers. So kind of think about this throughout the duration of the presentation, and we'll come back to this topic during the discussion period. Oh, sorry, there's actually one more slide until we talk about oral health inequities. But maybe I'll get through this, and then actually, do either of you guys want to add on to the commercial determinants before the discussion questions?
I think commercial determinants is shaping a lot of even of how. So commercial determinants is shaping at the individual level of, you know, one person. You can think that of our patient, for example, is shaping behaviors, is shaping attitudes, is shaping daily life activities for that individual. Then commercial determinants is shaping relationship between that patient, let's say with us, with family environment, and with their community and organizations. And then at the greater level, commercial determinants is shaping the communication of how things are portrayed to the public. So these are determinants that are in every spectrum of the what is called socio-ecological model, and the way they influence makes such a great impact that you can see how you can directly target, or marketing can directly target and get exact results of that. And so if there are no regulations, so this little comment is that if there are no regulations that considered health first, then those commercial determinants will maintain. So I always found, when I was doing the reading and then like making this association, it's impressive how commercial determinants can be placed in every single area of that spectrum of the sociological model, and that how only by regulations is a way to shape on a greater scale those determinants.
Yeah, that's such a great point. I have a pretty good example kind of policy, especially as it relates to alcohol and marketing in the Canadian context. So a number of years ago, I'm not even sure in the 90s or in the 2000s, but in Canada, it's banned to show a commercial, someone drinking alcohol in a commercial. They can be holding it, it can be on a table beside them as they're laughing with their family members, whatever, but you can't actually be showing someone drinking. And now I'm noticing in the last little while, sports betting and sports gambling has kind of become legalized, and now it's kind of permitted to download these apps on your phone and to be betting on sports games in real time. And there's absolutely no kind of regulation of what these corporations, these apps can, how they can market this gambling, and what they can say, what they can show, and what they can't. And I think that the commercials, they are so irresponsible because they are marking it as this like adrenaline rush, as this way to kind of participate in sports culture in a different level. And on the news, you hear a lot of researchers and mental health specialists kind of talking about gambling and the addiction of gambling and the mental health effects of gambling. And then when you look at kind of these commercials and making that link, and then thinking about, okay, well, will they ban something, certain messages that have to do with, what you can show as sports betting on TV, just in the same way as they did with alcohol. So, these things are really important. They shape so much of our health, and yeah, okay, I'll move on.
I thought about an example. So when we come to the example, remember me to share it.
Okay.
Including commercial determinants and equality inequity.
I just have the slide, and then we will get down.
Okay.
We will get to the inequities, I promise. But now that we've set up these kind of overarching concepts, I kind of wanted to take us back to oral health and how we think about oral health as dental professionals. Because as Alejandra mentioned, public health is a social science, and we're kind of making that link to the biomedical sciences. Because as dental health professionals, we learn about karyogenic bacteria and dental anatomy and histology and these biomedical aspects and functional aspects of having a healthy dentition. Obviously, that's very important, but oral health is more than that. And I really like this definition of oral health from the World Dental Federation, because I think it incorporates the social determinants of health into this definition. So this is straight from the reading, and I'm just going to read it out loud. So oral health is multifaceted and includes the ability to speak, smile, smell, taste, touch, chew, swallow, and convey a range of emotions through facial expressions with confidence and without pain, discomfort, and disease of the craniofacial complex. Further attributes of oral health include the following. It is a fundamental component of health and physical and mental well-being. It exists along a continuum influenced by the values and attitudes of people and communities. It reflects the physiological, social, and psychological attributes that are essential to the quality of life. It connects us to the social environment, and it is influenced by the person's changing experiences, perceptions, expectations, and ability to adapt to circumstances. This is taken straight off page 322. So when I read this, what I take from this definition is that health is a resource that contributes to our quality of life, but it is also a basic human right. I think we would all agree on that. And I am bringing this up because I would like for us to approach our conversation today on the social determinants of health and oral health inequities kind of through this lens of oral health as a basic human right and as social justice. Okay, as promised, the oral health inequities. So oral health inequities are differences in the rates of poor oral health conditions, many of which are preventable. So again, I want us to keep health as justice kind of in the back of our minds, because oral health inequities arise from the unequal distributions of power, income, goods, and services on a local and a global level. So inequalities and equities exist within and between countries. They disproportionately affect socially marginalized groups, specifically racial minorities, and they consequently lead to worse oral and systemic health outcomes. We're familiar with the link between diabetes and periodontal disease, and inequities are related to the timely access of affordable and acceptable healthcare. Inequities also lead to poor oral health related quality of life, both clinically and people's subjective experience. They also have an effect on our genetic makeup, which Alejandra will help us to understand through the socioepigenomics discussion that we are having on the next slide, Alejandra. So please take it away with your example, and then whenever you're ready, we'll move on to socioepigenomics.
Yes, so you know that obviously oral health is a mix of biology, your environment, your behaviors, and that the equilibrium of all of them and an individual as a human being is what constitutes our oral health. When that is broken, then disease comes. One of the ways that equilibrium is broken is, for example, through an unhealthy diet. Unhealthy diet, meaning excessive amounts of sugar, not obtaining the best quality nutrients from foods, from vegetables, from green leaves, things that we know that can maintain our oral microbiome stable. So one way in which commercial determinants impact diet and unhealthy diet is by targeting vulnerable populations. For example, here in the United States, while I was in the master's, I learned about like soda companies and some ice cream companies, well, sugar sweetened beverages and some ice cream companies were unfairly, unjustly targeting with their commercial people of color to sell to those individuals. So by inequities, they are most exposed to what is not healthy, and at the same time, given their social situation, they are not able to access any better option. So it's easy for the companies to target them because they know that that's the most accessible thing they have at hand. That becomes an inequity. And then also, they do not have the same equal access to healthcare as other groups may have. So as a loop, you encounter a person who's not eating appropriately, but that's the only thing they have at their hand. They cannot take care of their health because they have difficulties accessing health care. And then you have an environment through commercial determinants that is just reinforcing those bad components or behaviors that are rupturing your equilibrium, and then oral disease is rooted, essentially. So that was the example.
Yeah, that's a, I mean, it's not great, but it's a good example. And two, you probably know more about this than I do, Alejandra, because I don't remember the specifics, but I do remember hearing a couple of years ago, probably still ongoing, that also cigarette companies, tobacco companies were also strategically putting their advertisements in kind of racialized low-income neighborhoods specifically to target those groups for these same reasons. So you know, food, alcohol, tobacco, there's just yeah.
And that's why policy is so important, to regulate up to what point can commercial institutions or commercial you know, brands can go away with, but also is our challenge to educate and to use health promotion strategies and to be very creative in how can you address these patients with the conditions that they have. Because obviously, if you are not at a level in which you can make a policy change, you need to challenge yourself to work with what you can have under those conditions.
Yeah, and I think the really big challenge comes to when someone's use of kind of tobacco or sugar also is kind of normal within their community. Like, how are you going to also, you know, how do you do kind of promote good oral health behavior while still understanding and being empathetic and not victim blaming? And we'll also come back to that, I think, during the question period.
Yeah.
But I think that those are some great examples. Should I move on to the next slide for epigenomics? Yeah. Okay.
So with this slide, we can talk a little bit about one of the readings that was social epigenomics. Basically, the goal of this reading to this discussion, and when I read it, that was what stuck with me, is that we need to start thinking in a combined way, if you can call it like that, in a sense that we are not just social, we are not just biology, we are a combination of both. And when we start to understand that combination and that relationship of both things, and why does it occur and how does it occur, is when more questions will arise that will lead to more research, that will lead to the application of that research, that will enhance our systems, our clinics, and our approach to patients. So we know that, yes, social determinants impact our health. And then I was with this question, why? Like, how? How does that happen? And how can I combine both biology and social? So our entire body is made up of genes, right? All of our cells have genes. This is going to be like the very basic, brief explanation as possible so that it's easy to comprehend. But we are all made up of cells, and our cells have genes. The way those genes express is the way our cells will be and will function. Every single cell has the same recipe, but for different functions and for different things they do, that recipe is read in one way or another. Who tells the gene how to read the recipe? Those are called the epigenetic factors. So they are called biomarkers that you can see in the genetic strand that highlight the places that need to be read in a specific way in order for your cell to function in a specific way. The tricky part is that those markers are not, or can be changed. Okay, those markers can be changed and are influenced by the environment. And then that's how your social exposure to, let's say, adverse events, to stress, to an unhealthy diet, are introduced to your body through different other mechanisms and produce methylations or produce markers to be in not the right spot. And then your genetic is read differently, and you might be more prone to some diseases or other diseases just based on where you are exposed. This epigenetic research began with twins. If you have two identical twins, that their genetic is almost the same, but you have them placed in different situations, they were in different families, they were exposed to different dietary patterns, to different experiences. Both were completely different. One was perfectly healthy, the other one had entirely bad disease problems. And one was placed in an environment in which they had education, they had access to healthcare, they had good social economic status, they were able to afford good quality food, no problem insecurity, they had transportation, they had quality of life, while the other one wasn't or was in an environment with many needs. So this is an example of how your exterior merges or interacts or impacts your own biology, because at the end that's what is unbalanced. So, and that's when disease comes. So that's why I liked this article, because it was the first one that I could read that made that connection. Plus, from the oral health point of view, which is nice to have. If we are talking about oral health, it's the same. The way your genetic, one example of many, the way your genetic is read, the way that recipe is read in order for your enamel to be synthesized and your tooth to be grown with perfect conditions, depends on how those epigenetic factors are placed in the gene. If they are in a different way, given that the mother, talking about, let's say, primary teeth, a baby, the primary teeth are evolving, that pregnant mother was exposed to stress, to unhealthy diet, to all of these social determinants in its environment, that can have an influence in the way the enamel codifiers and epigenetic factors of the baby are read. And so that baby can be born with teeth with hypomineralizations, more prone to dental caries lesion to occur. So I put this example because in my area of research, I focus with mothers and babies to understand what happens at this stage. And you might think, why are you asking to a, I don't know, 12-year-old boy, what did the mother do when that mother was pregnant? And it's like, well, because I want to understand everything that might have happened at that moment that could have impacted the health of that person. And that's why now I am looking at 10 dental caries lesions in this mouth. So that's the purpose of this reading. I know that I believe in the discussion questions, we might have some about this, but if you want to jump in and give your take and what interested you maybe when reading this, Anna.
So the first time I ever really had exposure to this concept was not in relation to oral health, but it was on the Dutch winter famine. So that was cited in this article. And at the time of reading, I found kind of that study so interesting. So basically, in a nutshell, for anyone who's not familiar, didn't have a chance to read, there was a famine in Denmark, I think in the 20s, if I'm not correct. And so what they ended up doing is the researchers ended up doing a study with the children who were born from the mothers who had lived through the famine. And like many, many years into their later life, they were able to kind of make these connections about kind of their chronic diseases, their as it related to their mothers undergoing the stress of having no food and no nutrition, and how that impacted them at their early kind of life stages and then into later life, and just kind of showing how deep this goes. It's our genes, right? It's as deep as it can go, and how it just affects us throughout our whole lifespan. And yeah, and then when you shared this reading, the oral health component was really new to me, and I just think it's so fascinating, and it's just such cool research. And I'm so excited to like read and hear more about this, because I think this is like, you know, the next phase of the social determinants of health. We've talked about the social determinants of health for so long, and I think this is just the next iteration of it. And yeah.
Yeah, it's really interesting. And I think research of these is just starting, and the next steps are going to be very interesting. And my hope is that it becomes integrated. So it's not just changing one thing at the social level, or one thing at the clinical level, or one thing for education. It's thinking about all combined, even if it's a little at a low scale, but combined is better than big, just one disconnected part of the process.
Yeah, and looking at this, how it affects people throughout their lifespan, from early years, middle years.
Yeah, that's another a good, you brought it. That was another part of it, is that there's so much to try to understand. So at early life is the way your health is established, but then it changes throughout your life, right? And then there are determinants at each time point that can be very influential. So if you think about, and this is something that countries like Northern Europe have, is that they start thinking about late life when you're young. So that's a model that that maybe it's one of the ways that other governments can try to apply, trying to reduce late life determinants while you're still young. And it's kind of hard to picture, but it's one approach.
Yeah. Okay, well, why don't we move on to our question period, because we're essentially going to start off with our continuation of epigenomics. I'm going to stop sharing my screen, because that's the end of my slideshow.
Okay, so So this first part of the forum was very interesting, was to introduce some of these basic concepts. So now I'm going to share my screen to share the questions of the group number 2. Karla, please, can you read the questions?
Yes.
Okay, perfect. So I'm going to share my screen.
Okay.
So we could guide this second part of the discussion for. All right, can you see my screen?
Yes.
Yeah. I'm gonna read it. There is in English and Spanish. How can healthcare professionals and healthcare authorities incorporate a socio-exposure approach into the planning and the delivery of oral care services?
Okay, so I can start with this one. So because it's just what we just talked about. The social exposome is one of the ways in which you can understand the concept of how social determinants, social experiences, your environment influences and exposes the way your genes are translated and expressed. So for healthcare professionals, I can say that one of the ways is to start thinking through the systems thinking approach. And every time I talk about this, it's funny because when I read it, I said like, oh, it's actually not that complicated. It's just I didn't know it was called systems thinking. Systems thinking is understanding any problem, any situation as a system. And what does that mean? There are elements, okay, that are related to each other, but the sum of the elements do not necessarily produce the outcome that you expect. Like 1 + 1 + 1 = 3, not necessarily. So your systems thinking is more interested in the relationship rather than the sum of the elements. For example, dental caries. Dental caries is not just you eat sugar, you have a lesion. That's 1 + 1 = 2. No, we need to understand the relationship of why sugar, exposure to sugar, frequency of eating sugar, quantities of sugar, quality of sugar, absence of other things different than sugar, how that produces something that affects your health that then is expressed as a lesion. So that's one way in which we can approach how to plan your service, how to plan your individual consult with the patient, how to plan your clinic. If you start thinking to how the relationship occurs in a way that the exterior is impacting the interior, your clinic is impacting that individual. That individual lives in a place that environment is impacting him. How can we make both things work? So that's for the healthcare professionals. For the health authorities, I would say that one is tricky, but I think that coordinated approach is what I would always try to express if I have the opportunity to talk to people that are dedicated to making policy and changes. And coordinated approach means that you need to plan with goals in mind that are not disconnected. And the efforts you put towards oral health can very much be the same of what you put to other health problems. More so that we know that oral health shares risk factors with other health problems. So if you work in a disconnected way, you would only work towards funding programs for diabetes. But what if funding programs of diabetes connect with oral health, because they both have the same one of the same risk factors? So you combine efforts, you coordinate efforts. And the social exposome would mean that government will always try to address social problems. So if they address social problems, by default, they are addressing population and individual health. So I think that's the way I would try to influence policy.
I have something pretty short to add that I was thinking through as you were talking, Alejandra, and I think this maybe is useful kind of for the professional and health authority kind of approach, is just to think through this life course perspective, and for starting to think about a person's health in the context of their health from the time that they're in the womb, right? Whether that's as a dental professional, mothers are coming to you, or they're not coming to you, and they are not aware that they should be coming to you, or that they can be, that it's safe to be coming to you for dental treatment or examination during pregnancy, to know that bringing in a child for an examination when they're really young is, within the first 6 months of the eruption of their first tooth, or within their first year of life, that this kind of window of the first, I guess, is that the first 1,000 days of life?
Yes.
The first year?
The first 1,000, no, the first 2 years from pregnancy starts, 270 days, and then 365.
Not the best I can. Yeah, focusing our efforts, these combined efforts on maternal and infant health, and as it relates to nutrition for both mom and baby, and that can be both at the professional level and both at the kind of health policy level of what systems are in place for prenatal care. How does that connect to maybe diabetes and pregnancy, and making these connections, just like Alejandra said, if there's a diabetes program, if there's a young mother program, how can we kind of, instead of being like, okay, well, we have to focus our efforts on oral health, how can we kind of have this common risk approach to target and to be able to reach more people? Yeah, that's all I wanted to add. Just kind of think about the first stages of life and prepping for health, and then kind of having that strategy throughout the life course.
Okay, so we can go to the next question.
Yes.
Okay, let's see. Right.
Okay, yeah. What are the challenges and limitations to implement social exposome-based strategies in clinical practice and public health?
So I would say that one limitation is research. I think we need more research. And I think that clinical practice and strategies should come from applied research, especially in oral health or in our profession. We sometimes, and I say we because when I was studying, patterns were repeated, but then you start to realize, when I did the master's in public health, I did general public health and then did my concentration and always incorporate oral health. But you start to notice that we need more. We need more of these, of understanding the global scope to then bring it to our specific, discipline. But research is so important, and it is a limitation in this context. We need more advancement in the way genetics and epigenetics and biology is being studied for oral health as well. And in my opinion, or in my experience, better said, An example is dental caries. We often think about dental caries as lesion, which is the expression of a disease. And so what is happening with that disease? When did it occur? What could have happened with the mother and the baby in those 1,000 days of life that would impact that problem? What's happening later in life? That common risk approach. So all of that needs to be populated by research in order for good strategies to be implemented, to be effective, and to have the impact that we want. So for me, that's a great limitation. And challenge is maybe that we are just opening the door for coordinated programs, for a systems thinking approach, for digging in a different direction. And we are pushing for something that the majority not necessarily looks for. So we are thinking about upstream and the majority is looking downstream. So that's a challenge. That this approach, thinking about how determinants influence health, is an upstream approach. And that's a challenge. We need to push harder and to be outspoken and to advocate for these approaches in order to get good strategies put in place that we can have help and have support.
Okay, so Anna, do you have anything else to add, or we could go to the next question?
I'm good to move on. I don't have anything to add.
Okay, so the next question of the group is.
Okay, next question is, how can community participation and social movements be fostered to drive change in the social determinants of health?
Oh,
Shall I start?
This question reminds me of this community-based participatory research approach.
Yes.
Oh, maybe, do you want to talk about that, Camila?
You know, Alejandra and Anna speak first, and if there is anything else to add, I'm going to add it. I will add it at the end.
Okay, well, I can start, and then I really enjoyed this question because because like community grassroots activism and social movements, they're kind of fundamental to what is called broad-based community organizing. And it's driven by kind of social, economic, political conditions in which people as citizens live. So advocacy or community organizing is known as a driver of change in terms of making policy change. And it's the strategic organization of citizens as a methodology to enact change. Black Lives Matter in the US is a prime example. I know that there were protests in Peru over the government violating human rights over the past winter. And both of these examples we can think of as being rooted in the frustrations of citizens over the systems of power that govern them. So participating and supporting social movements through whatever channels are available to us can be fostered to drive change in the social determinants of health, because the determinants acknowledge that we can't be healthy if we live in a condition where we fear for personal safety, or if there's no access to clean drinking water. It's going to be much harder for us to have a healthy mouth in any of these scenarios. So I think kind of the takeaway for me when I was thinking about this question is that health is not separate, but it's part of this complex web of systems and structures, and to drive change in whatever we can as dental professionals, we have to use this privilege that this occupation gives us. You guys are, the next generation of dentists. You hold power and privilege to use your voice to embed oral health policy or advocacy into social policy and advocate in whatever way is appropriate for you in your community and within your capacity.
I can add, so I really like the way you answer the question. And what I can add is actually something that I learned when I was doing the leadership fellowship, and something that they always told us was for your group, for a group you're leading with, to produce change. In this case, let's say our community. So if we want change in the community, and they can be motivated enough to advocate for changes in social determinants, you need to buy in, to wait in. So that's a phrase, I think in Spanish I would say un refrán, that in English is said, the more you buy into something, the more you know about something and are involved in something, the more you are willing to work for it. What do I mean? And that's what community participatory research does, as an example. If you incorporate your community in a research, not just as subjects and participants of the study, but as actual researchers with you, they are an I'm losing the name in English, but that is your expert group. Your community can become your expert group in the community. You can learn from them, and they can be researchers, co-researchers with you. That's the principle of participatory research. You are buying them in. They would be more willing to do change and to understand why that is important. The other way around will occur if you become part of the community and you're not just, oh, I'm the dentist that comes, looks at people and then go, but you actually are involved in the community. You're buying into what the community needs. And then you are more willing to help advocate for whatever change needs to be done. So I think that the more we interchange our experiences and our knowledge, and sorry if there is a little background noise here in the house, but the more that you cross paths with other groups, the more you buy into something, the more willing you are to produce change and to foster movement and advocacy and raise your voice for something that is meaningful.
That's a great answer. I really like leading with.
Yeah, that were like very good answers, and this is very important. So let's go with the next question. And if there are also some questions in the chat that we will answer at the end, but let's finish with the questions of the group, and we could continue talking a little bit more about if there is anything else to add or to ask from the rest of the participants. Okay, so let's continue.
Okay, the next question is, are there criticisms or limitations of the salutogenic theory?
I can also start because I wanted to, when I was reading this question, I was like, okay, let's go back and define salutogenic model. And if we break down salutogenic, it literally translates to origin of health. So in dentistry, medicine, health sciences, we focus on etiology of disease. We've talked about this. What is the cause? What is the risk? That's the kind of conventional model of health. But whether there is disease or no disease, it doesn't give you the full picture of someone's oral health status, because our bodies, our mouths are part of this kind of greater environment. So with the salutogenic model, we start from the premise of health, and we focus on drivers and promoters and supporters of health, as opposed to approaching this from kind of the state of disease. So it doesn't mean that the model, doesn't consider risk or behavior, but it just approaches it from a different point of view because it sees health as a continuum. It sees this across a spectrum where each of us at any given point in time lies somewhere along this disease health continuum. And it acknowledges that health isn't just a dichotomy. It's not healthy or not. In terms of limitations and criticisms, I struggled a little bit with this one, but what kind of I had prepared is more so of the criticism as the salutogenic model relates to health promotion, because health promotion is just the process of investing in people to increase their control over, improve their health. And health promotion has been critiqued over time that it is vague and that it's not driven by theory. So the salutogenic model was proposed in the 90s by a researcher called Anatovsky. I can share his reading with you guys afterwards in the chat. Yeah, so for me, the limitation is more so with kind of health promotion as opposed to like salutogenic theory in itself. So please, Alejandra and Camilla, add on.
Yeah, I can add to that. That also part of the model when so I read the question and I went back to read the model again. And what they also talk about is the integration of behavior. And they say it's called like a sense of coherence, I think. And it would be behavior, your cognitive processes, and then your motivation. For everyone to understand behavior, and that's what I am passionate about because it's what I studied. Behavior it doesn't have one definition. It has multiple theories, and many scientists around the world for ages ago have defined behavior differently. And so the salutogenic theory takes one of many conceptions of what behavior is, and they say throughout the course of a lifetime, you're not just healthy or not. It's a combination of many things, and the sense of coherence of a person, which would be their behavior, their motivation, and their cognitive process, are impacting that healthy status. So the criticism, I think, is that before, this thought of how behavior is important for health change was not so evident. Whereas now it is taking more into account. So we know that behaviors and environment shape your health. The limitation is that we don't have all the tools and all the research to know how to appropriately incorporate behavioral focus programs in dentistry in particular. Other diseases, other health problems, other disciplines have started working with health promotion and with behavioral sciences approach to develop research-based, evidence-based, theory-based programs that uses salutogenic theory as one of their umbrellas and approaches, but in dentistry it is limited. And even though we educate the patient, you can search for oral health promotion programs, and we have many. How many of those are done with a evidence and theory-based approach using public health research? And how many of those are proven? So you can develop a model, you can develop a program, but then you need to prove it and make it as as evidence-based as possible, so then you can take and apply it to the clinic. So I think that would be the criticism and limitation of the salutogenic theory. But I do appreciate this theory as one example of how you can understand health from the greater view. And another criticism now that I remember is that sometimes the way the theory is applied incorporates, because it's dealing with behavior, incorporates these cognitive processes like emotions, stigma that you were talking about earlier, connecting with the person to understand in depth their thoughts. And before, maybe that wasn't thought, it was very a scientific approach. Now we have research using mindfulness and using religious prayers and a religious approach, because that's what's making people have motivation and have cognitive processes that lower their stress, and so they are more healthy. But before, that was more skeptic to use, like in a science or health field.
I just wanted to add on really quickly, because your explanation made me think of another possible limitation or criticism, in that health, if we think about health as being on a continuum that can change on a daily, it can change variably, then it's harder to quantify. It's more subjective. And in dentistry, we don't like that very much. Because, we can count how many cavities you have, we can measure all your pockets, and we can say how much of a percentage of 6mm pockets you have. But when something is transient and it changes and it's harder to measure, and I think dentistry is starting to do research that is outside of kind of just quantitative, but doing mixed methods research, doing qualitative research, and even things like oral health quality, related quality of life, like that is a subjective measure, but it is a validated tool to measure that. And so I think as dentistry becomes more innovative and there's more people that have kind of social science experience or interest to kind of merge with dentistry, because dental public health isn't huge, right? It's not as big as something like orthodontics. So I think as that changes, then maybe that kind of shift can happen more in dentistry on kind of, a level where we're learning about it in schools and our education.
Okay, perfect. So let's go to the next question. We still have, I think, apart from these, 2 more questions. But probably some of these next questions were covered a little bit before. So, but still, let's talk a little bit more about this. Okay, Karla?
Yes. As healthcare professionals, how can we actively participate to reduce or modify the corporate determinants of oral health?
So I think this one is tricky, because the way you can actively participate to modify, honestly, any social determinant of health, including a corporate determinant of health, is through policy change. That's how you can actively participate to do it. And the way to actively participate is to join advocacy. So advocacy in the means of a group, in the means of an association. Put your little piece of work that can sum to a greater pile. I don't know how to translate that in English properly, but in Spanish would be pon tu granito de arena en una montañita que se va a hacer cada vez más grande y que luego esa persona, nivel político, que tenga la capacidad de hacerlo, lo tenga tú pudiste poner ahí tu opinión. So you can share your opinion, you can participate in advocacy, you can try to make those changes. So go out of your comfort zone of your four walls. Even in a community center, you can advocate for change. Even next door, you can advocate for change. Even talking with colleagues in a scientific conference, you can advocate for change. And the more that opinion grows, a window opens in which policy can be introduced. I know that, speaking in particular for our countries in Latin America, it is very difficult to deal with policy. It is extremely difficult. It is difficult because it can become dangerous. So I know that that is horrible, and it's sad because you want your country to be better and to do better. But it's difficult to deal with policy in many Latin American countries. But as a means of hope, it would be that you can grow as a professional, look for other people maybe outside of your country that can help you, and improve your profession in any way you can with your opinion and with your voice at the scope and at the limits that you may, that you are allowed to.
Yeah, thank you so much, Alejandra. And I think that that's why it's so important to learn or to understand these basic concepts, such as these social determinants of health, because knowing that we could advocate for probably the correct things. So yeah, that is a very good start point, like to start to understand these basic concepts, and then to collaborate with other groups to advocate for these changes. Yeah, so Anna, would you like to add something else for this question, or can we move to the next one?
I do have something to add, unless if we're getting tight on time.
Well, we have 5 more minutes, but let's go.
It's okay if we go over? Okay. I was also thinking, about kind of this policy piece that Alejandra brought up. And I really wanted to kind of think about, as health professionals, kind of both on an individual level and then on maybe like a more of a macro level that's not necessarily policy. So on an individual level as healthcare providers, we're taught that there's right and wrong behaviors when it comes to oral health. And when we graduate, we're so eager to be good dentists, good hygienists. So we want to make sure we always remind all of our patients every time we see them what's good and what's bad. And I think one crucial thing to remember and realize is that for the most part, people know what the proper behaviors are for their health, right? Like they know what food is good to eat and what is not, again, very generally speaking. And I think as healthcare professionals, we need to acknowledge that poor oral health behaviors reflect people's environment, and that we need to avoid victim blaming and instead invest in our patients' health with them by learning about their day-to-day activities that shape their oral health practices and making suggestions to them specifically on how for them to better their own health within the constraints of their environment. And then on a macro level, all of us are consumers, right? We all consume food. And, I'd be lying if I said I haven't had a sugar sweetened beverage in my time as a dental hygienist. But we can use our voice as consumers and our dollars, our money as consumers by making choices on what and where we buy. I know I just spent so long talking about like how choice is constrained within our environment, but if we do have a choice to support responsible corporations versus those that are not responsible in terms of like corporate or commercial determinants of health, then it's on us to spend our money in a way that supports responsible corporations when we have that choice. And again, I'd be lying if I said I've never bought anything from Amazon. I have. And I know that that's not good corporate participation. And I know that there are better choices that I can be making, but that's kind of that self-growth and learning and kind of working our way. We can't always make the best, we can't always be perfect. And, just like that video at the start of our talk today, it's a big undertaking and it's tiring, and we have to also take care of ourselves and know that, we can make our mark and that it's important, and that one individual can have change, but also be mindful that, to have realistic expectations of ourselves too.
Thank you, Anna. Okay, so before we continue, I only wanted to ask Alejandra and Anna if you may have some more minutes to ask the next questions, or I don't know, we also can answer internally and send the answers to the group later on. But I only wanted to be sure if you still have some minutes to answer these questions here or later.
I'm fine.
Yeah, I can spare a couple of minutes. That's fine.
Yeah.
Thank you. Okay, so let's move to the next question. So I think that, I'm sorry. Oh,
Maybe this question. Oh,
yeah, there is.
okay. What new prevention and promotion approaches should we start implementing based on the salutogenic theory?
For me, is prevention and promotion. That's a good thing to discuss in another of your forum discussions. What's prevention and what's promotion? But I would say behavioral changes and behavioral approaches to health promotion is something that we can think about when we think about salutogenic. Behavior is much more than just individual characteristics, and includes the environment, and that social determinant impacts your environment and impacts your behavior, and so your health. So if you're thinking about salutogenic theory, a behavioral approach for health promotion can be one option.
Okay.
Yeah, just to add on, again, I would go back to health promotion, and just like Alejandra said, like that's a whole topic on its own. But implementing promotion strategies that are upstream and kind of start from the premise or the question of what can we as health professionals do to promote this individual or group of patients to move along the continuum or the gradient of health, kind of as they move throughout their life to better health, right? Like how do we but how can we support people in making the decisions that are good for their health, and that those decisions are the easy decisions. And I think that's, again, going back to that systems approach and working through the social determinants of health, the commercial determinants of health, and kind of realizing that health is not just the responsibility of us as healthcare professionals or the healthcare sector. And it's not just an individual responsibility, it's a societal responsibility that needs to be shared across healthcare systems, across sectors. And again, like, I just really want you guys to, you all to kind of leave feeling like, okay, you have the knowledge, you have the voice and the power to promote oral health in a way that doesn't just see an oral cavity as being disease-free or in a state of disease, but supporting your patients and your community of patients along this gradient throughout their life.
Okay, thank you, Anna. So only I want to read the two questions that we have on the chat. One question is from Diana Camargo, and she asked, so do you think that this approach about, I think that the social determinants of health is adequate to explain most of the causes of, I think, of oral health diseases and in the design to public policies? And then we have another question from Beatriz Chileno, that is, while the dental curriculum in undergraduate programs is focused on teaching students about the disease that affect the dentition and oral structures from a biological and clinical perspective, education about the social determinants of health is frequently regarded as less important. So how could public health professionals impact in the educational area? Okay, so please, if you can provide us some thoughts about these two interventions. Thank you.
I can start with a Spanish question. And Anna, you can take the other one if you want.
Gracias.
So, I would say yes. This approach, in my opinion, is a right way. Well, I would not say the right way, but it is a good approach to explain changes in oral health. Oral health ruptures or disease comes through, oral health disease comes through if there is an imbalance of your biology with your genetics, with your environment, with you as a human being, and all of that is influenced by your social space, and so your social determinants. Public policies aim to better social determinants independently, sometimes coordinated, but most of the time independently. So if public policies are targeting social determinants, and then you add to that the benefit of doing so because of health, then I would say this is a good approach to make politicians worthy of what they do.
Okay, thank you, Alejandra. Okay, Anna, can you answer the next question?
Yeah, I'll answer it with a personal story, actually. So when I was in my dental hygiene training, just like you guys, you know, I had some education on community oral health and the social determinants of health. And I thought that, you know, my education on it was pretty good. It was enough. And during my time in my hygiene training, we had a placement, a practicum, and I went to a local public health unit in Toronto. It's called Toronto Public Health. And I loved my experience. It was my first exposure to public health. And in the Toronto Public Health system, basically hygienists go into schools, they screen kids. Any child that has some kind of, that has active decay, has, you know, is kind of marked as having a need to see a dentist is sent home with a note. And then they also have like a clinical aspect where they see kids and seniors that are living in low income. anyway, the point of my story is that I left my training feeling so good about the social determinants of health, and I really wanted to get a job in public health as a clinical, like as a dental hygienist working in the clinic. I sent out resumes for years and years and years and years and years. I never even got an interview. And I was so upset. And then I decided to go back to school. And now that I'm in my master's studying about public health and getting this education at such a deeper level, I'm like, of course, nobody even gave me an interview because I didn't know the right terminology. I didn't have the right words. I didn't have enough education to be able to convince these managers of public health programs that I understand that health isn't, that health is social and that it is constrained by our experience. And I think, how could public health professionals impact the educational arena is by knowledge dissemination and by presenting at conferences, leading these study clubs, kind of opening this conversation of dental public health within the dental community on kind of one side, but on the other side, within public health kind of more generally, also paving way for oral health. So kind of having like two sides of the same coin, right? Because I don't know, Alejandra, it would be really interesting if you want to comment on this, but you are in like a general master's of public health, and how many other oral health researchers or oral health professionals are in your program?
So this is very interesting because there are oral health professionals, so there are dentists in the program, but the program itself do not incorporate oral health as it incorporates other disciplines. So from the start, from my very first day, I was doing all of my work using oral health, dentistry, oral health diseases as my means of work, as my topics, as my health problems to solve. And that's when I realized that it's both ways. Public health as a great discipline is missing, or now is just starting to include oral health, but oral health is missing public health. And so a connection needs to be made between both, and that, as the question asks, should start in undergrad, for example, when we are doing our dental degree. And healthcare professionals, I can talk for also as an example, my experience, many of the doctors that were my professors, they had their own private clinics. They are healthcare professionals. So the more they gain knowledge about this, the university fosters knowledge about this, and that is translated to students, the better chances are that those students are willing to also go the route of including public health in their approach, and not just have the 3-5 questions about demographic and some determinants at the beginning of the chart, but having an in-depth understanding of why that person is there with pain, with problems, and not just something happening in one tooth. So the dissemination of knowledge, as you said, I think it's very important. And that's something that we can do.
Yeah, totally agree. And that's why it's so important also to promote this discipline about dental public health. Dental public health specialists are needed in many parts, in different parts. And one important part is in the universities to make changes in the curriculum and include these important topics, right? But unfortunately, we don't have a lot of dental professionals involved in public health or dental public health. Most of the dentists are more focused on the clinical area. And at the end, we have these limitations and challenges. We want to change. We want to make some changes in the university area or in the political area, right? So, oh, thank you so much, Alejandra, Ana, Karla, and thank you so much, everybody, for your time, for participating in this second discussion forum. This was so interesting, so helpful. I hope that most of the conversation provide a lot of in-depth insights to think about it also later. We recorded all the forums, so then all the members of the group will be able to see with the transcription, with the subtitles. So I know that most of also the group probably are not able to understand everything because it's in English, but don't worry, we will share. Vamos a compartir esta grabación y con los subtítulos para que también lo puedan ver. Así que no se preocupen si no entendieron todo, pero ha sido bastante interesante. Y aparte, el grupo va a hacer un resumen de lo que se ha conversado para compartir en las redes sociales. Así que I only added, Ana, that the group will do a summary of what was discussed today. So also we will continue disseminating this knowledge to the general public that it's so important. So as a thank you for your participation, the study group wants to provide you this certificate. To
Muchas gracias.
So for Ana and also for Alejandra, we are very grateful with both of you. And also, I hope that we can continue collaborating between each other. There are a lot of undergraduates, graduates, and also alumni of dentistry here in this group that are very interested in this discipline. And I hope that also you can continue providing them more like feedback, or if there is any other member of the group who have another questions, please, I hope that they may feel free to contact both of you. So thank you so much. I'm going to stop sharing my screen.
Yeah, anyone, please feel free to contact me. Thank you so much, Alejandra, as well.
Thank you to you, Anna. It was a pleasure to work with you, Cami, of course. And congratulations on this great project. And we need more of these.
Yeah,
all over Latin America, all over the world. So I hope to see this initiative grow, because I think it has a lot of potential. So congratulations for the efforts that you have made so far.
Thank you.
And thank you, Karla. Well,
yeah.
Thank you so much.
So
I learned a lot with all of you. Thank you so much.
Thank you, Karla. So before we finish the recording and the meeting, please, pueden prender todas sus cámaras para tomarnos una foto final. So also Ana and Alejandra can know your faces. Yeah. Y vamos a tomarnos una foto final de recuerdo. Did you notice that most of the members of the group are women?
I did, other than Fabio. Or Diego. Oh my God.
Diego, thank you for joining us today too. I know that you also enjoy this type of conversation. This is a very, very interesting topic. Okay, so I'm going to take the picture. There is anything, ¿hay alguien más quien quisiera prender su cámara para la foto antes de que la tome? Ok, bueno, voy a tomar la foto. 1, 2 y 3. Una más. Listo. Gracias a todos por conectarse y ya pronto les vamos a compartir la grabación. Thank you so much, Ana, Alejandra. So hope to see you in Colombia, Alejandra, too.
Yes.
Hopefully. Okay, thank you so much. Bye-bye.
Bye.